So hello, good afternoon everyone. I'm Jo Bibby, I'm the Director of Health at the Health Foundation, and I'm going to be chairing this webinar this afternoon. I've got a few slides just by way of introduction and scene setting, and then we'll be hearing from our two speakers. So we move on to the next slide, some housekeeping things first. As you'll have seen, the meeting is being recorded. If you could please keep yourself on mute when you're not speaking, and ideally turn your camera off. We have a Slido account set up so you can submit questions for the speakers. So you can see there the website and the event code, and we're also putting it in the chat so that people can go to it if they arrive after you do. Closed captioning is available. So find the stream text link in the chat box if you need that. If you have any technical questions as we're going through, you can email the support team at events@synergy.co.uk. So now just next slide, quick overview of the agenda. We'll just, as I say, do a bit of scene setting. Then we're going to have a presentation from Professor John Wright, Director of Research at the Bradford Institute for Health Research, followed by Professor Ruth Dundas, Professor of Social Epidemiology at MatchNet. We'll then have around 15 minutes for Q&A before we close at 1:30. So quite a tight schedule and lots to get through. Now, just to set the scene, the programs you're going to hear about today are both funded through what's called the UK Prevention Research Partnership. And it's a £55 million multi-funder initiative. You can see on the slide all the various funders who are contributing to this. And it launched, I think, around just over 2 years ago now. And I'd say it really was novel and groundbreaking when it launched, in terms of really wanting to bring together a wide range of disciplines and stakeholders with a very strong focus on end user need to build evidence to help decision making, to look at the common upstream determinants of non-communicable diseases, and seeking to find scalable actions to enable change within complex systems. So a very ambitious but highly relevant set of objectives. And the first round of the programme, and if we go on to the next slide now, funded 4 large consortia bids and 4 network bids. And this series of webinars is going to be a chance for people to hear about all of these projects, with also some chance to reflect on the policy implications that they raise. So today we're focusing on the 2 awards that relate to children's life chances, but we have other ones coming up over the next couple of months that will be exploring the other topics, such as commercial determinants of health, urban planning, and so on. Next slide, please. There is also a further round of awards that have recently been made, and these projects are really at startup phase at the moment, but we'll be hoping in due course we'll be able to share with you some of the findings from those as well. Next slide. So today we're going to focus on health in early years. I'm sure everybody joining the call today will know absolutely that children growing up in poverty and in low-income households experience many disadvantages that can have negative health consequences through childhood and into adulthood. Next slide. So it's really great. This morning we're going to hear about 2 pieces of work. The ACT Early Research Consortium that John Wright is PI for, and the Maternal and Child Health Network that Ruth Dundas leads. And both of these are in different ways researching the complex ways in which disadvantage influence child health. They'll be sharing insights from their work and reflecting on how policy can be improved to increase opportunities for children, particularly living in poverty. Next slide. So with that, I'm going to hand over to John, who will speak for 25 minutes, and then we'll go on to Ruth.
So my name's John Wright. Joe, what a great introduction. I think the UKPRP is a really internationally groundbreaking funding scheme because, as we know, nearly all research funding goes into the biomedical side of things. 90% or something like that goes into the clinical biomedical research. And whereas 90% of our health is determined by these wider determinants. So the UKPRP is quite a brave initiative to try and redress that. I'm going to talk a little bit about Act Early, one of the first consortium that was funded, as Joe mentioned. We're 2 years in, and having just returned from a week's holiday in the beautiful Northumberland coast, I think programme grants are a little bit like holidays. You spend the first couple of days thinking of, you know, endless days in the sun and having picnics on the beach and all that sort of stuff. And then suddenly the halfway point arrives and time speeds up exponentially. And the next thing you know, you're packing your bags. So we're in that nice phase of still being not yet halfway through. And I'm going to share a little bit about the background of how we came up with this and how it's going. So City Collaboratory is really the essence of what we're trying to do. And when you think about how things are, you know, how we look at, for example, Joe will know about Jönköping in Sweden, about an exemplar that the Health Foundation used to be very closely involved in. For quality improvement. If you're interested in physics, and you go to CERN in Switzerland. If you're interested in rockets, you go to Los Alamos in California. But when you're interested in prevention, it's a much more difficult, much more complex thing to address. And because it's about populations and it's about systems and it's about complex systems. So how do you know, developing a Crick Institute in London for biomedical research, that's a piece of cake. Might be complicated research, but doing something around really tackling up wider determinants is much harder. So this idea of a whole system, City Collaboratory, really underpins what we're trying to do in both Bradford and in Tower Hamlets. And we have two centres. The first one is Bradford, where I'm from, which is really sort of, this is something we've been working on for the last 15 years, and I'll give a little bit of background to that. But we were also very keen to see if we could replicate the model. You know, this is something that we've got a lot of track record for, but could you take a greenfield site or brownfield site even and develop it? And so we teamed up with Tower Hamlets and UCL in London to develop this really strong north-south research partnership, pulling in the interdisciplinary expertise across the universities in Yorkshire and in London, but focusing it on two areas where there's high levels of deprivation. So for Bradford, we set up Born in Bradford about 15 years ago, and it's become one of the sort of big birth family cohorts in the UK internationally. And it's grown from just being an observational cohort to involving experimental cohorts, evaluating different early life interventions. We've got about 50,000 people involved in the study in the city. So it's become quite a sort of focus around the importance of early interventions, about the importance of early life and determining our adult outcomes. And our children are now becoming young people. So the oldest ones are 14. And over the last 14 years, Born in Bradford's created its own little mountain of science and knowledge, starting off very much with the clinical biomedical side around genes and, you know, diabetes and pregnancy and that sort of stuff, but increasingly recognizing the wider determinants shaping the health and well-being of our children. So, for example, while we've created, you know, lots of great insight into new genetic pathways for drug discovery, a lot of the work is concentrated more recently on the harms of air pollution, the benefits of green space. We've come up with some fantastic stuff around food systems, you know, identifying pesticides that were banned 30 years ago that are still in the blood of our children, showing that our telomeres, our strands of DNA on our chromosomes are shrunk, our biological clocks are harmed by the closer you live to an air polluted road. All this sort of stuff at a molecular level is fascinating, but it doesn't change what we need to do. And after a while, you start getting into this pattern of everything fundamentally is socially determined. All the diseases that we were tracking are fundamentally shaped. Every time a new paper came out, you could tell that the poorest children in our city were being harmed the most, whatever adverse outcome it was. So there was a sort of frustration that we were just describing the problem over and over again, rather than coming up with solutions. And when we think about those complex, wider determinants. This is a picture from Ian Beasley, one of our artists in residence. And it sort of captures those wider determinants. So these three young boys, you know, they will be growing up in housing that is poor quality, it's damp, it'll be rented often, so the kitchen may not even be able to allow you to cook. The green space that it will overlook will be poor quality. There'll be lots of busy roads around, so lots of air pollution, lots of traffic accidents, food swamps when it comes to fast food outlets, and food desert when it comes to healthy food choices. Schools are struggling because a lot of the children have English as a second language, so you're struggling to get educational attainment at the same level as you would do in the leafy suburbs, and lots of crime and lower employment expectations. So if we're going to tackle this, we need to try and think less about individual exposures and risk factors and more about how they interact together. And this is something that you'll all be aware of. You know, this is a classic foresight map of a complex system around obesity. Complex systems, these are some of the things that really sort of underpin our theoretical thinking about these wider determinants. The idea of unintended consequences, of dampening effects and accelerating effects, of feedback loops and unintended consequences. And while theoretically we understand, this is like climate change, it's something that's quite intuitive. We recognize it in the world around us. When it comes to practical examples of putting this into research, there's very, very few around. So one of the things we wanted to do is to try and translate this complex system, whole system approach into our city collaboratories. And we came up with this idea of Act Early, addressing these wider determinants, whether it's built environment, urban design, transport, schools, arts, culture, social justice and housing, and focusing our research strengths in the north and south on populations of great need, applying epidemiology and co-production, modelling, evaluation, but fundamentally trying to build places where, rather than scattering public health interventions across the country and hoping they have some sort of magical effect by targeting a single exposure, that we try and put them together, understand how they interact and see whether they have this tipping point. And this is a classic component of a complex system, is that this idea of a tipping point. We know about this from climate change because we're pretty close to that tipping point. Can we do the same in public health? And things like childhood obesity are a good marker of this. Childhood obesity is so complex exposures on this, but it's a good marker of the wider determinants around us. So I'm going to give an example of that. This is 7-year-old Samira, and with an intervention around school super zones, which is being trialled in London at the moment. And you can see that on her way to school, Samira is exposed in an inner city environment to air pollution, traffic, which is trying to run her over. The poorer kids get killed more often by cars than the richer kids, less green space, and then days of inactive, being dropped off at school, and then sedentary days at school. Half our children born in Bradford are of Muslim heritage, and so 90% of those go to madrasas after school. So they rush home, Coca-Cola and crisps, and then to the madrasas for 2 hours. So this is again further sedentary exposure. And how can we address this? It's not about tackling the madrasas, but it's about how we tackle the whole school day, the whole day for Samira. And then in her neighbourhood, she's got fast food outlets and unhealthy school meals. So these are multiple exposures. If we can tackle them together, then we've got a chance of not just addressing outcomes such as obesity, but also things like physical activity, educational attainment, and mental health. So trying to explore the interactions of these exposures and the outcomes is quite fundamental to our approach. Underpinning this is the importance of community co-production. And this is one of the first things that we put our heart and soul into. Coming up with a very innovative community citizen science and community co-production approach. This takes us beyond our traditional NIHR approach around patient and public involvement, which tends to be very clinical, I find that NHS still roll out patients when it comes to public health interventions, and we need to take a different approach to this. If we're serious about getting this change, it's got to be organic, it's got to be grassroots, it's got to come from the people. This is not a paternalistic, we're going to do this to you. This has got to tap the potential of our communities and how innovative they are. And so our approach is to develop this through an asset-based approach. Appreciative inquiry is the approach we're trying to do, defining what we mean, discovering what works well, dreaming about what could do better, and then designing and delivering. And we're embedding this into all our intervention developments, but also at a meta level as well. Data is the second pillar that we're working on, recognizing that if we're going to both understand our populations, but also to evaluate efficiently, you know, it costs, these programs are £5-6 million, £1 million a year. Your average randomized controlled trial costs £1 million or £2 million just for one intervention. So if we're going to evaluate multiple interventions, we need to get better at using novel methods. And to do that, we need more routine data. And that's linking in the richness of our public data sets that we have at the moment, contributing things like cohort data that we have through Born in Bradford and developing similar sort of things in East London. Born in Bradford's got this fantastic rich data set, so we're very lucky with that. And we built that, particularly, this is just an example from the Bradford side of things, but using pseudonymized linked data, which links in primary, secondary care data, social care data from children and adults, education data. One of the remarkable things about Born in Bradford, the richness, was just the power of this routine data. So the connected Bradford data set, and a similar thing that we're doing with the discovery data set in London, is to really underpin what were the evaluation components of this. And to do that, we've taken this whole system data accelerator approach, public engagement being the starting point, embedding it into policy and practice, both clinical and public health policy, making sure that all the legal and ethical approvals are done, the IG is covered, all the technical issues of data linkage, and then importantly, how that's owned by the system and visualized and accessible by practitioners. So when we set out, we had this sort of idea of sort of where these interventions are going to come from. We had examples of funders that we were already working with. We wanted to develop the sort of horizon scanning about what we could be testing in our city collaboratories. And these tend to be sort of three main areas. One, partner-led interventions, sort of researchers coming up with ideas. Secondly, which is probably the main area that we're focusing on, is natural experiments. Lots of things going on every day, lots of changes in local authorities across systems. How do we take a complex intervention approach to help theoretically underpin these natural experiments, so that how we can test and refine them to improve their stickiness, but also adapt and refine them, and work out whether they save any money fundamentally. And then the simulation model, which I'll mention in a minute. So where are we 2 years in? We started accumulating interventions in our three main themes: healthy places, healthy learning, and healthy livelihoods. And these are things like livable streets, school streets, clean air zones, green space redesign, and healthy learning, lots of stuff going on in the schools. And we developed two cross-cutting themes, one around food and healthy weight, and the other on play and physical activity. So we have theme leads for each of these. The trick is to try and to get them to work. And inevitably, something in our human nature is that we retreat back into sort of project management mode, and trying to get people to work across themes is difficult. But if we're going to take a complex systems approach, we need to try and do that a little bit more cleverly. And in terms of the research evaluation, because this is a research program, we're taking a number of different approaches. The bottom left here is our traditional project evaluation, which is experimental and quasi-experimental approaches, and qualitative. There's a meta evaluation about the whole city collaboratory in Tower Hamlets and Bradford. What difference does it make on longer term outcomes? There's a methodological innovation component to this, because a lot of what we're trying to do is quite innovative. It's moving beyond just experimental methods. And then the research on research. One of the goals behind the consortia was to develop, consortia of researchers. And so we're looking at things like social networking analysis and looking at how we've created new partnerships across our academic partners. So taking novel approaches to evaluation, I think, is something we've got to be much more rapid at. Our local authority partners are not interested in RCTs that are going to take 4 years to come up with an answer for. The answers, the questions that they have, that they need answering, need to be answered almost that day. So we've got to get a bit slicker in how we do this and a bit more routine in how we help them evaluate what are multi-million-pound changes in policy. And then Richard Cookson and colleagues at UCL are also leading our simulation program. This is, as well as the traditional intervention studies that we're doing, looking at short-term effects, starting to look at what this means if you model across the life course, both early childhood outcomes, but also using our fantastic national cohorts to model what the effect is in adulthood. And this is an example of one of our complex systems maps, our social networks. This is always work in progress. It shows on the left side some of my fantastic collaborators, of which there are many, and then on the right-hand side, some of the agencies involved. And over time, this captures both personal links and how we're developing them across the country, north-south in particular, but also the organisational links and how we start shaping the science and evidence. And then how finally how that science and evidence is used is really fundamental, because we are not interested in research for research's sake. We are all very committed to making a difference within our lifetimes, we hope. So this is less about publishing papers in journals and more about how we translate our research and science into routine policy, so it becomes part of the town halls and becomes central to that. And we've seen what's happened with COVID over the last 18 months, how science and evidence has really come to the fore. Can we translate that to everything else other than public health? So can we turn that into education and social care so it underpins our decision making? And this is our stakeholder analysis framework that we're using, which sort of marks out different groups depending on both influence. So, for example, national politicians tend to be the most influential, but often have the least interest. And the public tend to be both variable interests, but also not very influential in what you can do in terms of policy. So our sweet spot here is the co-production on the top right of trying to get working with policymakers so that they are interested. We are answering questions that are important to them, but these are the people who are making the decisions. So that's the sweet spot that we want to try and do. And I think that is all from me.
Great. Well, thank you, John, for that. In a moment, I'm going to hand over to Ruth. What I just wanted to remind people is we have a Slido site set up. The details for the web link and the code you need to put in are in the chat. So if you are able to, if you have any questions, log on to that and we'll have some time for Q&A at the end. So please do that. Right, I am now going to hand over to Ruth. Thank you.
Okay, great. Thanks very much. And thanks for inviting me to present today. As Joe said earlier, I've been asked to talk about the kind of policy challenges and then any sort of discuss implications of these for the early years. And my perspective is a bit different from John's in that MatchNet is taking a sort of national approach to policies, but there's definitely learning, I think, from local policies and implementation to national policies. And I think it goes both ways, that national policies are often implemented at local levels. And so it's through this learning about local implementation that can then inform national evaluations of policy. So there's definitely synergies there. So why should there be investment in early years to improve adult health and reduce inequalities? Well, as Joe and also John said earlier, having a good start in life during pregnancy and infancy has been shown to be important for both living a healthy life and a longer life. And health and well-being during the early years, which can start pre-conception, has a crucial impact on chronic disease and inequalities sort of across the life course and also from one generation to the next. We know that there's good evidence about the impact of intrauterine and infant growth and preterm birth on cardiovascular health. And the determinants of infant and child health, I mean, they might be complex and they're also interrelated, and they range from family socioeconomic circumstances, childcare settings, through to neighbourhood deprivation and pollution, as mentioned by John. And there's been various sort of initiatives, and one of them was the First 1,000 Days initiative, and this concept started in 2010 with Hillary Clinton, and this was at an international conference on global child undernutrition. And really it's influenced health policy in high income countries, including the UK. There was a recent UK parliamentary review and they took evidence about this first 1,000 days. And the idea is that the first 1,000 days from conception to about age 2 is a period of rapid growth, and what happens during this time lays the foundations for future development. And that might not be particularly new for people in the area of infant and child health, but I think recently it's got more traction in the kind of like wider health sphere, as Michael Marmot had it as one of his recommendations in the Commission for the Social Determinants of Health. And this graph on the bottom left is a Heckman curve, and it shows that the highest rate of economic return comes from the earliest investments in the life course. So it just shows that the economic benefits of investing early and throughout childhood provide greater success to more children, and therefore greater economic productivity and reduced spending for society as a whole. There is a willingness to invest in the early years. We know that there's many governments, it's not just the UK governments, that have strategies and policy in place. And there have been some evaluations of these early year policies. So in Manitoba in Canada, they had the programme for the Healthy Baby Programme, and that was for low income pregnant women and then for their children. And this had minimal effects on outcomes when they did the evaluation, but they did have some positive benefits for one of the subgroups. And in Sweden, they had the Salute programme, and this looked at the effectiveness of a universal health promotion intervention. And they did find limited immediate positive impact on child and maternal health outcomes, and they're going to continue to follow them up to look at longer term outcomes. In Scotland, they introduced the baby box for all newborns. It contains kind of things that are needed for the first few weeks, like nappies, nappy bags, cotton wool, baby grows. And this baby box has been a policy in Finland for about 80 years, but no one knows the effect on health outcomes. And in the UK, there are several other policies in place, such as the enhanced provision of early years childcare. There's the Healthy Start vouchers and a previous universal policy, the Health and Pregnancy Grant. So as I said, there is a willingness to invest in the policies with the aim of improving early years experience, but how do we know if these policies are working? So a real challenge for the policy is that old what works, for whom and in what circumstances, and I suppose for child and maternal health at what stage of the life course. But there have been only a few outcome evaluations of such policies, and that's despite this House of Commons report on health inequalities, and that was published in I think 2009, maybe 2010, and it states that there is an ethical imperative to develop and use evidence-based policy. All the reforms we have discussed are experiments on the public and can be as damaging in terms of the unintended effects and opportunity cost as unevaluated new drugs or surgical procedures. And such wanton large-scale experimentation is unethical and needs to be superseded by a more rigorous culture of piloting, evaluating and using the results to inform policy. And then they bemoan the fact that when evaluations are done, they're usually sort of process evaluations and not outcome evaluations. So in order to make this sort of challenge of evaluation a bit more tractable and possibly tackleable, if that's a word, John outlined the sort of complex systems and how tricky that might be. I can try and split this challenge into a series of smaller challenges, and I've laid them out here, and then I'll take you through each of the challenges in more detail. So first of all, to improve health, we need to identify what drives health, and that's the social determinants of health. And then there's the underlying policy landscape. So what else is going on either at the same time or at different times or in different contexts. Then there's the individual policies that are in place. They need to be identified. And once that is done, we need to identify suitable exposures and control so that we can make the good comparisons. Then identify the data sources that can be used. and then finally use a strong design and robust methods to evaluate them. So crucial to our understanding of population health are the social determinants of health, and John also talked a lot about these. So these are the conditions in which we're born, grow up, work and live. And this diagram is from a paper by Anna Pearson, the Archive of Diseases in Childhood. And I think it's a really good visual representation of the social determinants of health for children. And it's put into the rainbow model, and it's adapted from Bronfenbrenner's Ecological Systems Theory of Child Development and the Social Model of Health by Dahlgren and Whitehead. So you can see here at the centre of the rainbow is the child, and they're largely kind of fixed characteristics. And surrounding this are the concentric layers of influence that are potentially modifiable, the social determinants of health. And each layer is further from the individual, and then eventually reach the outer layer, which are the macro level circumstances, so the political, cultural, commercial and economic conditions. And you can see here in the diagram from the arrows that all the social determinants are interrelated both within and between the layers. So a real understanding of the importance of the social determinants of child health across the different sectors is needed for policy so that there is an improvement in health. And I think it is a real challenge to get non-health sectors to consider the health effects of any policies that they're doing. But not only that, it's the opposite is also true. I think it's really important to get health departments and people who are interested in health and have health as their remit to consider non-health policies and how that affects health too. Next one is policy landscape. So what else is going on either at the same time or in different contexts. So we know that policies are not introduced by free will. There's a political environment. So if you think about the situation in Scotland, at the moment, the UK government has the power over the welfare system, but the Scottish government have introduced some mitigating policies. So the Scottish government can't change the amount of money that's available for welfare benefits, but they can bring in some policies. So they brought in the Better Start policy, and they can give lower income families some extra money and support. Also need to identify the policies, and as I've said, they're not necessarily in the health or the public health policy area. We need to look at the social determinants of health, so across all the sectors ranging from employment, education, environment, health, housing and welfare. We need to be able to identify the exposed group and a suitable comparison group, so a suitable unexposed group. And this can be difficult at the population level when health records are not necessarily linked to exposure data. So we don't have health records linked to the welfare policies. But you could use eligibility criteria potentially within these data sets to construct the exposed and control group of those who meet the eligibility criteria or don't meet the criteria. So it's not necessarily those who receive the dose of the policy. And I suppose an example of this can be policies aimed at supporting teenage mothers. So you could identify teenage mothers in your data set, and you don't necessarily know whether they had the policy, they were exposed to the policy or not, or whether they had a dose of the policy. But you do know whether they were a teenage mother, and this can be thought of really as a kind of intention to treat analysis. So it's how the policy is working in practice. But that might not be good enough for a robust evaluation. So having the data linkage would be much stronger. And that leads on to the different data sources. So data collection for policy evaluation can be difficult. And if you're trying to evaluate a policy that's already in place, it can be nearly impossible. If you haven't collected pre-policy data and the baseline data, how do you know that the policy has made a difference? But administrative data or routine data offers a real opportunity here, because that's obviously collected through time, and these can span families, they can span the life course, and they can span different government sectors, and they can be used to evaluate the policies. As I've said previously, having the data linked across the policy sectors is vitally important, and we need to know the welfare status or the early years educational provision and also the health outcomes for children to evaluate these policies properly. And John showed a really nice example of how well that can be done locally with his Born in Bradford cohort of children, and how they've got these local links, and they can or these local relationships, so they can then link the data. But we really need this to be available nationally as well. And the population level impacts of national policies on long-term health outcomes and inequality, they can't be examined in trial settings. You need to use other methods of evaluation, such as natural experiment designs or other evaluation methods. And as well as the outcome evaluations, you really do need to do the economic evaluation alongside. So I showed earlier that Heckman makes a convincing argument that the earlier you spend in the life course, the better value for societal benefits. But we really should test this and do the economic evaluation policies to know that we're spending their money in the right way. And this is really where MatchNet comes in. So that's the Maternal and Child Health Network. And that offers a real opportunity to work on some of these challenges. The UKPRP have funded us to do horizon scanning for the policies, for the data and appropriate methods so that we can evaluate the prioritised policies in the future. So in order to understand how interlinkage of policies can modify the determinants of child health, MatchNet focuses on 3 policy intervention periods, so pregnancy, infancy and the preschool period. And these lie within the policy landscape. And as I've said earlier, they might differ across the 4 UK nations. And within these landscapes, there are different policy departments which may impact on the health outcomes. And cutting across the intervention periods are the linked maternal and child data sets within each country. And again, that's got the potential to create whole country longitudinal birth cohorts. And this opens the potential for data sets from different sectors to be linked into the birth and the health data. And stakeholders have input across all the stages too. And we really need all 3 of these areas to come together so we can have in-depth knowledge of the policies, the administrative data and their timelines and the measures available within the administrative data and the evaluation methodology to do the evaluations of the prioritised policies. And so what are the implications, I think, of these challenges? I've tried to talk a little bit about the implications as we're going through, but just in sort of summary, there is a need for the recognition that child health is important for adult health. If we get it right in infancy, then that can track through to the adult health. As both John and I have said, the determinants of infant and child health are affected by the kind of macro level policies, and they have the potential to improve the health of the mother, the index child and subsequent children and possibly even the rest of the family. And ultimately we can then reduce these non-communicable diseases. So it is important to have the right policies in place to allow children to have the best possible start in life. Intervening at the macro level of the rainbow is crucial, I think, for improving health and reducing inequalities. And policies and strategies that can tackle these multiple layers of the social determinants have the greatest potential. And I say that we do need a better evidence base. Currently, there have been few experimental or even quasi-experimental studies examining differential effects of interventions or policy changes by socioeconomic circumstances. And this leads to the inverse evidence law. So that it means that there's least research on the interventions or policies that are most likely to have the largest population health impact. There is a real willingness across governments to spend in this area, but we do need the robust outcome evaluations of the policies to ensure that the money being spent is on the right policies that will improve health and lead to a reduction in health inequalities. And finally, I'd just like to acknowledge the funders and to thank the co-investigators and members of MatchNet, in particular Emma Stewart and Anna Pearce, for the conversations that have shaped the ideas in this presentation. So thank you all for listening, and if you want further details on MatchNet, visit our website and follow us on Twitter. Thank you.
Great, thank you, Ruth. Okay, so okay to stop slide screen sharing. Brilliant. Okay. Great. Well, we've had a few questions coming through on Slido. Just apologies, somebody helpfully spotted that there was a digit missing in the code, but the correct code is there now in the chat. So anybody with questions, please do keep adding. I'm going to start with one which I think applies to both of the projects, and that's about how co-production is shaping the direction of your work. So John, I just wondered if, starting with you, if you could just say a little bit more about not how you're doing it. I think the question is probably how is it actually changing what you're doing, and then Ruth, I'll come to you.
Yeah, I think there is this sort of meta approach to co-production about how you get people involved in the communities and tapping into the networks that allow you to do that. So not reinventing wheels. And in places like Tower Hamlets and Bradford, there are very, very strong voluntary sector and community networks. So there's a bit about, just as we developed a social network map for our academic and organisation and our agencies, there's a bit about doing the same, about building on what's already there, because this is not, you know, tabula rasa. So then at an individual project basis, I think it's about, it's really about starting with the views and the getting the public involved in what's happening in the design of interventions, in the implementation of interventions, and the evaluation of interventions. And we've been able to do that in things like clean air zones, about how that's built across the city. In terms of new green space interventions, very much about what's important for people, about how it links into, you know, school days and things like that. So design that people can use it. I use a classic example as a cycle path between Leeds and Bradford. I think it costs about £1 million. It's a lovely cycle path. I use it fairly regularly, but no one else uses it because nobody else cycles from Leeds to Bradford. Everybody cycles in from the outside of Bradford in, like commuting, and the outside of Leeds into Leeds, but they don't go necessarily between the two cities. So there's a bit about designing from the start about what actually is important for people to use. And then the citizen science bit is the other important part for us, and particularly with young people. How we really get people excited about the science and research. You know, fundamentally, our goal is to, you know, health is so linked to educational attainment. And if we can inspire young people with science and research, then we will probably make more difference in terms of the health than anything the NHS can ever do. So getting them excited. And we've got lots of great examples about collecting data and getting involved in your DNA and collecting samples of air pollution and that sort of stuff.
Yeah, great. Well, thank you. That does sound interesting. Ruth, where does Housekeeping fit in with what you're doing?
Yeah, I mean, MatchNet is obviously slightly different to John's project in that we are not funded to do research. We are sort of setting up this community. So it's, you know, started off from zero or maybe a handful of people and then just getting everyone else involved in this sphere. So we're, you know, bringing different stakeholders from different places together. So, you know, building this community who want to use routine and admin data to evaluate the national policies. And that's been really, I think that has been really productive. And in terms of co-production, you know, bringing third sector organisations with government organisations, with the public health agencies and with us as researchers, we had our ideas about what policies might be important and interesting and what outcomes might be important and interesting. But actually in speaking to, you know, the different people involved in MatchNet, you know, they have brought new outcomes to us. A lot of them are interested in school readiness, so not necessarily hard health outcomes that you might think of. They're interested in the kind of wider sort of cognitive and socio-emotional development of children, which is really useful to know. If we can find these measures in administrative data, it's helpful for us to know that. And also, they've been really important and key in the policy prioritisation exercise. So, you know, we've been consulting with them as to what policies do they really want to evaluate, what policies do they think are really important for maternal and child health. And it's been interesting having the conversations with people from the public health agencies who then say, oh yeah, we would be really interested in understanding, you know, universal credit and welfare policies and how that would help with health, but they don't have that. I don't think luxury is the right word, but that's not in their remit. So it's not something that they would necessarily be able to do without us kind of like facilitating these conversations.
Great, thank you. I mean, that's a nice example of how you talked about changing the things that you're potentially looking at by involving some of the end users of what you do. And it links to another question, which I think, Ruth, you probably covered, but John, maybe you could just say a little bit more about how you've involved policymakers early on in your work and what difference you think that might make to their receptivity to the findings.
Yeah, I think that's been one of the big changes for us. Is about so the two chief execs of the local authorities. From the Bradford side, Kirsten England has been involved for the last few years. So she's sort of with the programme. Will Tuckley at Tower Hamlets, it's been new to him. What is research, what are academics, tend to be fairly irrelevant to most jobbing chief execs of local authorities. But over the last couple of years, he's seen the value, the importance from everything from co-production, from the data linkage through to the potential for interventions and understanding, as Ruth pointed out, that moral argument about having evidence about what we do if we're tackling inequalities. So they are central to everything that we do. They are part of our board meetings, our steering groups, our workshops, and through that leadership, they then have their senior teams engaged with us, and that's one of the most powerful things is that meshing, dovetailing between our researchers and our local authority staff, and it's fairly new.
Yeah, that's good to hear. And I think it's fair to say that one of the kind of design features of the UK Prevention Research Partnership was having kind of end users of the evidence in the room. So it's good to hear how that's happening. Ruth, I'm going to go back to you now with a question that is specific to your project. Somebody's has asked the question of whether you're going to look at the impact of decommissioned policies. I think this is a really interesting question, actually, isn't it? Because often we do see things that we know are helping and then they stop. So where does that fit into your plan?
Yeah, I mean, as I say, MatchNet is kind of like laying the groundwork so that eventually by the end of MatchNet, we might have a beautiful research proposal like John's to be able to then have 5 years funding to, evaluate some of these policies. So MatchNet won't be evaluating them, but what we're trying to do is find out what the policy priorities are with our end users. And some of these might be the decommission policies. And actually, good evaluations of policies can be relevant to all policies of the sort that are being evaluated, not just the immediate policy. So I think any evidence does have value, even if that policy has been withdrawn. And I think it is important that there might be some policies that were in place in past, evaluate them. Can we reintroduce them or find out? I suppose it's the discussions as well as to why they were withdrawn or how they were withdrawn. But I think, yeah, definitely we've definitely gone for a wide scope of policies and horizon scanning. They might not have come up in the policy prioritisation exercise, but again, it's something that we can definitely go back and speak to the kind of end users and the users of the research about and say, would you be more interested in finding, having research that will help you with policy or that policy or ones that have been withdrawn? We're certainly not ruling them out, definitely. There's definitely learning there.
Right, thank you. So again, there's a couple of questions that are in a similar space, so I'm going to put them to both of you now, although slightly tailor them. One question is about, well, they're both around inequalities, as we know, largely being driven by economic conditions and obviously poverty. So there was a question that's more aimed at the Act Early project, which is about how you're measuring the impact of interventions on poverty at individual family level or city level. So it'd be good to hear, John, your take on that. And then perhaps a kind of slightly broader question for you, Ruth, which is asking whether we need to, given that so much economic inequality is kind of baked into our system, what does that mean in terms of the sorts of outcomes we should be kind of, in a sense, realistically being expecting policies to deliver? So that question there really about the role of economic inequality, poverty, on how we can bring about change to health outcomes.
Yeah, it's a very good question. We're not measuring income as an outcome, and this is where health is fundamental focus for our outcomes, but education as well. And as Ruth alluded to in her talk, there's things at a national level that you can't influence, and taxation and distribution of that taxation is something that we can't do. And we've seen, we are in the current government through, national insurance increases, which has been a regressive taxation, and through the reduction of universal credit. These are things that we can't influence, and it's frustrating. But if we can't influence things at a local system for our, 500,000 people in, Tower Hamlets and Bradford, well, close to 1 million people. then I feel that it's a bit disempowering. So there are things that we can influence, and that's built environment and schools and place and communities, which are really fundamental. And there's things that we can't, and we need to recognise the differences between those. But I think, at the same time, there's things like some of our interventions that Kate Pickett is my colleague who's leading the Healthy Livelihoods theme, is around putting welfare advice into GP surgeries, into health settings. If you can put more money into people's pockets through getting better welfare advice, that's a very simple thing of where you're just giving advice to get. So it's the existing system of support, welfare support, but you're just getting better access to it.
Thank you.
Yeah, I think it is a tricky one, as John says. There's not really, they're probably huge effects, but we don't necessarily have we know that they're good levers to pull, but can we actually pull them? So as John says, you might be able to make an influence on air pollution by, stopping cars or increasing active travel or something like that. But, if we can show, I think if we can find the robust evidence, it's more evidence to keep hammering people with and say, we haven't done the robust evaluations. There's an evaluations going on with colleagues of mine in Glasgow at the moment who are looking at the health effects of universal credit, mainly I think in adults at the moment. So, when that's been funded or worked or shown, it's going to add to the evidence base that more money is needed, or welfare reform is needed, or universal credit isn't good for people's health, or maybe it is good for people's health. Once you've got that evidence base, you can start to then have the conversations. And if you can, have the conversations with the people who are going to be presenting policy, or, they might not be the actual decision makers, but they could be the people underneath who are creating policy and influencing policy, who are interested to come along and hear what your results are from universal credit, then maybe it's all helping. It's not necessarily going to change the world. We've all been doing this for quite a long time now. Not much has changed, and it is hard to pull these policy levers, but if we keep building the evidence base, then maybe things will change.
I think actually when you were presenting, Ruth, I was feeling a little bit more optimistic, in that I think things have changed. I mean, they do take a long time and they move slowly, but actually, certainly some of the recognition around the importance of early years feels to be much more widespread and widely held than it possibly was a decade ago. So I think we should be optimistic. Two more questions that are slightly more tailored to each of you. The question of whether MatchNet, Ruth, is contributing to the development of the Health and Social Care Bill legislation, because it talks about having bespoke guidance to children, young people and families. So maybe you're not, and maybe there's an opportunity there that someone's flagged, but if you've...
It's not something that we've been aware of and been participating in that consultation. We have participated in other consultations round about sort of like data linkage and improving measures for measuring child poverty and improving, the benefits of reducing child poverty. But that one certainly sounds interesting. So if who's ever suggested that would be good. We can't promise everything to everybody in MatchNet, but we'd certainly have a look at it and see if we are able to, get involved in some way.
Great, thank you. And then John, a question somebody posed, which also did go through my mind. The scale of what you're doing in Bradford and Tower Hamlets is huge, in terms of the areas that you're looking at and the range of interventions. How optimistic are you, and what kinds of things do you think might come out of it that will be generalisable to other places?
Yeah, I think the proposal was written with the idea of replication in Tower Hamlets, so that both the process and the evaluation, the meta evaluation that Maria Bryant, my colleague from York, is leading, will give us some idea about that. So it's important that we work on, what the evidence about that generalizability. I think there'll be lots of I think there'll be lots of lessons and more process type evidence about which will inform things like, you know, this big call out, HDRC call out nationally to across the devolved nations, which I think will shape some of that learning as well. So I think, you know, this is very much the CMO Chris Whitty's goal when, you know, before the pandemic, was to try and get more local authority research systems, and that in many ways were the sort of trailblazers for that.
Thank you. Okay, so one final question to both of you to finish on, which is, somebody asked, what's a surprising lesson or lessons that you've learned so far, so halfway into the project? Anything surprising you've learned? Ruth, would you like to start?
Yeah, I'm thinking that's quite an interesting question. I'm not sure. I think the most surprising thing, which is probably not really about early years and child health and policy implications, been because MatchNet started in September 2019, we were just about to have, by the time we'd set everything up and got everyone together, we were just about to have our first kind of like in-person meeting of all the co-investigators in April 2020, and our first policy roundtable in June 2020. So neither of those things happened, and we still haven't met face-to-face with all our co-investigators. And I think the most surprising thing is not necessarily COVID itself, but just how well we have adapted and changed, and how the people, as I say, I acknowledged Emma Stewart earlier, but how adaptable and how amazing she has been in keeping us all together and keeping us all on track, and working out how to do things instead of in person, but do things online and do things differently. And so I think it surprised me how adaptable we've been, but also how sort of people can really step up and change and do things and help us improve in that way. So if we're improving MatchNet in a good way, then maybe that is positive for maternal and child health at some point, Jo.
Yeah, I think something that's probably surprised a lot of us, that. But John, just a quick word from you on that.
Similarly, the pandemic provided the biggest surprise to us all, I think, just starting 6 months after we began, but it also provided us a chance to become useful to the local authority, particularly Bradford. We set up our own SAGE, our COVID Scientific Advisory Group at Bradford, that became central to the decision making. And from being, you know, at a sort of irrelevance to our senior policymakers in the city, suddenly we became at the heart of our district goal command, our clinical goal command, and became really, really useful. And it's that legacy now of then thinking, well, actually, science and evidence does have a place. Can we apply it to other areas? So it's that pivoting has been the biggest surprise, and how we've been shown our use.
Great. Well, thank you both for your presentations and for fielding those questions. And I think, you know, perhaps just that final observation is, I think that one of the real powers of the UK Prevention Research Partnership and the way it's been set up is this really trying to create the evidence that practitioners and policymakers can use on a sort of more day-to-day basis. And it's great to see that those kind of design principles are coming through. So just in close, we've got a slide, I think, just to highlight the next webinar we have in this series. As I say, we're running 4 over the autumn. That will hopefully come up on the screen, but if not, I can tell you that it's on the CIPHER. It's coming up now. I think it's the CIPHER Consortia Award, which is correction. Sorry, it is the CIPHER Research Consortium, and it's being presented by Julian Cox, who's head of research at Greater Manchester. CIPHER is doing some really interesting work looking at how you can understand the effectiveness and cost effectiveness of wider policies, so that genuine health and all policies approach, looking at the impact of different policies, economic policy, transport and so on health, and looking at that both at city level and country level in Scotland. It's going to be chaired by Sophie Hawksworth from Wellcome Trust, one of the co-funders, and Greg Fell, Director of Public Health at Sheffield City Council, who are one of the test sites, will be joining that discussion. So thank you everyone for joining us. Please do register for the further presentations we have in this series, and hope that we will also hear back from the presenters in due course when they're packing their bags at the end of the holiday and sharing some of their findings. So thank you very much.